All right, beautiful. Welcome everyone to another webinar with yours truly, Dr. Emily Splickle, founder, CEO of Naboso, and also founder of EBFA, which is an education company. So depending how you found out about this webinar, it was probably from one of those different entities or possibly on social media. But my goal through this webinar and through this lecture is to bring some clarity to the high arch, which is referred to as the cavus foot. As I mentioned before I hit record, we do a lot of content on flat feet, pes planus, different types of overpronation. What is the effect of this overpronation? And then it's like the high arches or the rigid feet kind of get forgotten. So I wanted to do a webinar focused on that foot type. And if you happen to work with patients or clients, then of course you have to understand all different types of feet, not just flat feet, but also what is happening on the other side of the spectrum when we start to get into this supinated foot. My background real quick, just in case this is the first time you're hearing a video or a lecture from me. Dr. Emily Splickle, functional podiatrist. This is my practice here, Center for Functional and Regenerative Podiatry. My website is thefunctionalfootdoc.com. I see most of my patients virtually, and I proudly practice as a functional podiatrist and a human movement specialist versus kind of a traditional way of thinking of podiatry and foot care. In addition to that, founder Naboso, EBFA, authored several books. I have a new book coming out, so stay tuned. This will be in the next several months. That book is called Sensory Sapiens, so definitely stay tuned for that. Okay, so as I had already kind of warmed up the tone, is that not all feet are flat, and not all foot imbalances or dysfunction, you could say, is falling under the overpronation, pes planus, or flat foot side of the scale. There are many people with high arches, which is referred to clinically as a cavus foot. So if you ever hear that word, that is essentially what it means. So when we are thinking about a foot that is cavus, higher arches, this is really falling under supination. Okay, so supination is going to be the opposite of pronation. And I have a couple photos to show this and demonstrate this, but the flatter foot equals pronation, overpronation, unlocked, unstable. These are essentially associations that you can start to make with a foot type. Cavus on this side is going to be higher arched, more rigid. We could start to use the word supination, over supination, right? And the components of supination is going to be plantar flexion, adduction, and inversion. That's essentially the components, the triplanar components of a cavus foot. So when I look at a foot that has high arches, I see plantar flexion. Now, what this means to you, the listener, is that oftentimes someone with a cavus foot, high arch, will have limited ankle dorsiflexion. So that's one of the presentations or associations that you can see with this foot type. Okay, and that's really where we're trying to understand this. So having a plantar flexed ankle means that there will be limited ankle dorsiflexion. Someone with high arches may have a hard time being totally flat, like wearing minimal shoes, wearing like flip-flops, wearing ballet flats, being barefoot in their home. They might feel like it starts to pull on their Achilles tendon, on their heel, and on their plantar fascia. So that is an association. Okay. Inversion, I'll show you what that means in a photo in a moment. The inversion is going to be what's happening in the heel bone, and it's essentially locking or making that foot rigid. Okay, so just higher arches, you're going to think more rigid foot. Rigid meaning doesn't take impact well, like stiff, right? So when someone has tight hips, right? Like a locked hips, a locked pelvis. These are words that equate joint stress due to impact, due to gravity. Okay. Now, dorsiflexion of the midfoot, that's essentially what's giving it the high arch. It just means that the arch is lifted. That's what dorsiflexion of the T&J means. Okay. Then I'm going to show you another foot type that's called anterior cavus. Okay. So anterior cavus. Now, before this, there was a really good question that I want to make sure I'm sharing here. Meryl asked this question: what would be the cause of a high arch, but high over-pronation? So I'm actually going to leave that question, Meryl, now that I saw the whole question, because it's a little bit different. What I thought her question is why do people get high arches? Where overpronation is oftentimes muscle weakness. It's a compensation for limited ankle mobility. It is ligament laxity. So there's different causes of having overpronation in a flat foot. Oftentimes, cavus feet, global cavus, anterior cavus is structural. So it's a little bit of the cards that you were dealt in a sense. Some of that is obviously coming from your parents and genetics and how things are passed down. But foot type in the higher arch becomes a little bit more structural. That is just part of your foot type, kind of like I'm short, my boyfriend's tall. I have high arches. He actually has a metaductus, which I'll show you in a little bit. They're just different types of foot structure. Little bit different thought process than the overpronated flat foot, secondary to the possible weaknesses or compensations that I just described. Okay. Now, what I want to go in next is that we are going to talk about the subtalar joint. Now, the subtalar joint is the heel bone. So if you wanted to stand up, and if you stand up and move your foot in a certain way, so all the way to the outside, to the inside, just like on these photos, as you roll to the outside of your feet, just like the photo to the left, you are theoretically inverting your subtalar joint. When you invert your subtalar joint, you lock the rear foot, making it rigid and stiff. Now, functionally, inversion is a position of power. So we want to be able to invert our foot. We have to pass through inversion when we take a step. So I don't want you to think that I'm saying inversion is bad or eversion is bad or pronation is bad or supination is bad. They're all just moments in time. And it's when we get a little bit too extreme in those positions that it starts to have an effect on the body. Or if we are standing statically in a position like on the left, what I see when I look at this foot on the left is, yes, that is a high arch cavus foot with a supinated rear foot with a lot of pressure on the outside edge of their heel. They're going to wear down their shoes accelerated on the outside edge of their heel. That is going to increase the risk of ankle sprains. When we invert our heel, we technically externally rotate our hips. So oftentimes people with this higher arch inverted supinated foot on the left is going to have really locked down hips. Sometimes their pelvis and their sacrum will be tucked under and they're going to have low back pain because they're just locked in their pelvis. Those are associations of what we are establishing from this static inverted foot type. Okay, hope that makes sense, right? So we have to be able to dance in and out of these positions. I want you to understand what inversion means, plantar flexion means, supination means, but when we're too supinated or too inverted, then we become excessively rigid, stable, locked, and that can cause stress to the system, okay? Dynamically, inversion is how you unload energy. It's how you accelerate. We have to be able to invert and lock our rear foot when we jump so we can release sufficient power. So we have to be stable to release power, right? So that's a positive aspect of inversion, okay? Now, cavus feet typically, so if you have a client or you are a listener who has a high arch and you want to understand your foot type a little bit more, oftentimes there's going to be mid-foot rigidity. So in the middle of that foot, sometimes people will say they get top of foot pain, right? That's just essentially saying that your midfoot isn't unlocking well. So when you move and run and jump, you just bang your bones together and you get top of foot pain. It's oftentimes associated with higher arches cavus feet. Limited ankle mobility, I've already explained that one, and that's because you're technically in a plantar flexed position. Because you're in a plantar flexed position, you put a lot of pressure on the ball of the foot. That is called metatarsalgia. Ball of foot pain is metatarsalgia. And then when you have more of your body weight pitched forward, you give a mechanical advantage to the extrinsics, and you get an increased risk of forming hammer toes. So if I have a patient that has high arches cavus foot and they have hammer toes, I'm not surprised. And they complain of metatarsalgia. Not surprised about that either. Then they have limited ankle mobility. Then they're telling me they have top of foot pain. Maybe they got a stress fracture in a base of one of their metatarsals. Not surprised. Again, they're just associations of the foot type. Okay. So this is going to be a high arch, a cavus foot. Hopefully you're starting to recognize that as we're standing here, that there's this lateral pressure. So you can see how they're more to the lateral aspect of their heel, right? How is that going to wear down their shoes? Where is that going to put stress through their foot? They may have a hard time connecting into that hallux. Absolutely. If you're working with an athlete and they have high arches cavus feet, you want to make sure that you're doing the work to really connect into that hallux. Now there's two main types that I'm going to start with, and of course there's more, but two main initial types of cavus feet. You will have what's considered a global cavus, and you will have a anterior cavus. So a global cavus foot, which is kind of what you could say that I have, and I have my camera's blurred, but if I relax my foot, do you see how my forefoot and my rear foot are on the same plane, if that makes sense? Even if I do that, so now I'm relaxing my ankle, okay? That is going to look different than, look at this center picture. Do you see how the heel is here? And then it's like the forefoot is on a different plane down here. Do you see? It's almost like they're in a high heel open chain, right? And I see this all the time. And I posted this on social media. Ooh, sorry, you guys. Posted this on social media, and people will comment and say, that person wearing too many high heels. Shame, shame. Well, one, this is a man, and the man is not wearing high heels. Maybe he is. I don't know. But you do not get anterior cavus feet from wearing high heels, such as this. This is his structure. This is this individual's foot type. This is what he was born with. Foot type, anterior cavus. An anterior cavus is just a little bit more exaggerated on these symptoms. So it's going to be even more limited ankle mobility. It's referred to as pseudo-equinus, even more pressure at the ball of the foot, even more risk of hammer toes and pressure here. So I just want you to understand this anterior cavus versus a global cavus. It's an important distinction. I see a lot of anterior cavus in my office, and we just want to understand, because ultimately your goal when you approach feet, whether it's your feet or a patient's foot, is you are trying to balance pressure under the foot. Yeah, pressure and force. Okay, now one other thing that this patient has is a little bit of a metaductus. So what I'm doing is I'm holding his rear foot in neutral, and then if I look up this way and I'm trying to find the bisection point of his heel when I put his subtalar joint in neutral. And do you see that the foot looks like it's a little bit skewed, right? Almost like a C-shaped foot. That is called metatarsal adductus. If you have metadductus with a cavus foot or with high arches, it makes the foot even more rigid. That is structure. You cannot reverse structure. right? Unless you do surgery. So what I do in this case is I'm just educating. I'm educating the patient about their feet. I'm educating, did you know you have a metaductus? Okay, so if you're getting top of foot pain, makes sense, right? We have to slowly increase stress to the foot a different way. We're going to focus on mobilization. We're going to balance it with met pads, and I'm going to show you the other ways that I like to do it. But essentially, that's a component of Cavus feet that you can see, metaductus, okay? All of my Cavus foot assessments, I'm looking at the foot open chain from the side like this. I'm looking at it open chain like this to assess for any metaductus. And then I always look to see where pressure is. This person technically has a plantar flex first ray. You can see that this is sitting lower than the rest of the foot. So it's going to put a lot of pressure here. Okay. Now, that is a structurally cavus foot, which is one that would be highly functioning foot, genetic foot type, right? There is another type of cavus foot, and you cannot have a cavus foot conversation without talking about the neurological foot. The neurological cavus foot is a very distinct foot. It is very similar to what we're observing here in these photos. And what is happening is that when we have certain neurological conditions, spinal cord injuries, strokes, MS, Parkinson's, Charcot-Marie-Tooth, whatever the presentation may be, we can start to see that there is this kind of drawing in of the foot. And do you see how the foot gets pulled in? The top of the foot here pulls up. We're plantar flexing a little bit. The toes curl up like this, right? And that foot is essentially locking and becoming very, very rigid in like a super cavus foot. This is progressive, and this is purely based off of the neurological muscle imbalances that are happening because of that neurological injury. It is oftentimes inevitable. It cannot be stopped entirely. I work with patients to try to slow it down as much as possible. I try to bring relaxation to the hypertonic muscles as much as we can. I try to balance force and pressure under the foot so that this is not extremely painful for the patient or the individual, but it's something that we also have to educate the individual that this is a progressive feature of whatever their neurological injury is, right? And we can't, unfortunately, fully reverse it. Here's another example of one. So you could see how it will present unilaterally on someone. Obviously, the left side is where they had the neurological injury. Foot is pulling up really high, plantar flexing those metatarsals. So the metatarsals are plantar flexing very sharp, giving a mechanical advantage to the extensors, creating the hammer toes. That creates a lot of retrograde pressure. So there is a lot of metatarsalgia here. And then you can see how it's pulling up here as well. And they would have very limited ankle mobility as well. Okay, so just so that we can understand that, here's Charcot-Marie-Tooth. This is a motor sensory neuropathy where you will start to see this. You'll start to see degeneration of the muscles, of the peripheral nerves, and then we just start to get this foot that pulls in like this, in addition to, of course, muscle wasting that is characteristic of this condition. So I just want you to understand that as well, okay? Global cavus feet versus anterior cavus feet. What does cavus mean, and what is the functional impact of high arches at face value, right? We already went over that. There is something that falls under the neurological cavus foot. Why is that happening, and how does that present different than a global or an anterior cavus foot? And then understanding really what is our goal in all of these different versions of a cavus foot. Okay, so hammer toes and cavus, this is going to be very, very common. People with high arches very oftentimes will have hammer toes. So when I have a patient with high arches, I am always getting them in toe spacers. Hammer toes are, of course, progressive. Hammer toes can be dynamic, which means when our foot is in our shoe, we have no idea what is happening, which means that we could be contracting, inclining, and creating these hammer toes with every step that we're taking. And we don't even realize it because we cannot see in our shoe. So I absolutely love using toe spacers as a way to create a stretching effect, long, straight, flat digits. This is for everyone of all ages, even if they are not reversible. So when I see hammer toes, I will try to pull them straight and start to classify and understand, are these hammer toes flexible or rigid? If they're flexible, then definitely try to keep using those toe spacers to try to reverse the contracture and get the toes to relax. If they are rigid, which means you try to pull them straight and they're stuck, contracted, that doesn't mean don't use toe spacers, but we're just trying to get a little bit of opening even though those toes stay contracted, right? How do we create as much comfort, for this patient as possible? Okay. This can be very, oh my goodness, right? So when we have hammer toes, this is not just in the neurologically cavus foot, but high arches, tripod feet. So oftentimes people with a cavus foot, high arch can have like a tripod foot, and they got pressure submet 5, 1, and heel, and it's very rigid, or they're getting a lot of entire ball of foot retrograde pressure, and they can get these very painful calluses here. So you want to make sure that you're debriding those and you are allowing forefoot pressure to be balanced. I'm going to show you metatarsal pad in a moment, just in case you've never heard of a metatarsal pad, but you're really trying to open up and take pressure off of the ball of the foot. Okay. Now, something else that you can see in a high arch cavus foot is a Haglund's deformity. A Haglund's deformity used to be sometimes referred to as a pump bump. And why it was called a pump bump is that all the women wearing their pumps, I don't know when this was, maybe the 80s, something like that, where they were wearing their pumps to the office, and then they started to get irritation of the heel bone against the stiff counter of the stiletto. And when you are in a heel, like a pump, your foot goes into a plantar flex position and you rotate like this. You could see my heel rotating. So now I'm going to hit this piece on the shoe, hence the pump bump. However, in people who have cavus feet, it is very common to have a Haglund's deformity. So if you are looking here and you're looking at any of your clients or maybe yourself and you're like, what is that bump that is on the back of my heel? I swear I never had that, right? So you had it. It was probably just not irritated. There was a bursa that sits over that. And if that bony prominence gets irritated, the bursa can get inflamed, the bursa fills with fluid, and then it essentially becomes more prominent. It can be very, very painful when I have patients with a Haglund's deformity, but you are essentially trying to take pressure off of that counter. So this is just something that we see oftentimes in higher arches cavus feet. This could be almost like an example of like a figure skater who is getting irritation and they happen to have a high arch cavus foot, and the figure skater is getting a lot of Haglund's kind of bursitis pain because of the skate, their foot type. Technically, a skate is a little bit plantar flex. Some of them are. So it depends on and how it presents. But I just want you to understand that as well. And then because they're in a plantar flex position, they have a increased risk to Achilles tendon symptoms because of the limited ankle dorsiflexion. So that is common with a cavus foot, okay? And not done yet. And because your Achilles tendon blends into your plantar fascia on the bottom of the heel, plantar fasciitis is very common in those. It's common in all foot types, but it is common in cavus foot types because oftentimes their plantar fascia is on end stretch, which means just at baseline, you can see their plantar fascia. I actually have a case study that I'm going to show you on that. And that is why they're just uniquely susceptible to plantar fascial symptoms. Okay. So when I am starting to approach the higher arched cavus foot, just based off of everything that we presented already, I am trying to bring mobility and balance to this foot. I want to mobilize the rear foot. I want to mobilize the midfoot. I want to mobilize your foot to hip. So focusing on the hip is very important as well. We know that there's going to be an increased propensity for hammer toes. So we're going to use toe spacers. Toe spacers every night is an awesome way to recover a cavus foot, even if there's no problems, no pain, and you're essentially just saying, I have a cavus foot. What can I do to keep my feet healthy and strong for the rest of my life? Then I would say use toe spacers every night. Release the bottom of your feet every single day. The reason is that the 26 muscles in the bottom of your foot, 26 muscles in the bottom of your feet are actually inverters. So they make your feet more rigid. And if your foot is already rigid because of you having a cavus foot type, we need to really focus on intrinsic foot mobilization. In addition, posterior tibialis, which is down here, this is the inside of your foot. Sorry, you guys. Coming down your leg, it's going to come here. It's going to insert on the inside of your arch. That's your posterior tibialis. It inserts on your arch, and then it fans out, and it has 9 attachments on the bottom of your foot. So when you release the bottom of your foot, you're actually releasing that broad attachment of your posterior tibial tendon, which your post tib is a supinator or an inverter. It lifts your arch and it makes your foot more rigid. So that is why I am all about the neural ball release. So toe spacers, splay it away, intrinsic foot release, neural ball release, brush your teeth, release your feet, morning, evening, boom. Metatarsal pads, love these. Absolutely, absolutely love these. I think my next slide shows it. Yes. Okay, so here's your splay. Here's your neural ball release right here. This is a Met pad. And the Met pad is designed to go just short of the ball of the foot. So how this is, I would actually move this Met pad about down just a couple millimeters. To me, it's a little bit too high, maybe even 1/4 inch. I would move it down. And the purpose of a Met pad is that when you walk, you're going to walk. You have a Met pad here. You're going to hit the Met pad, and then it's going to pop, and it's going to open up your Met heads, create a transverse arch, and balance pressure across the ball of the foot. So really, really good for people with metatarsalgia, cavus foot, anterior cavus foot, neurological cavus foot. We are trying to balance pressure. The dancer's pads that I like are 1/4 inch felts, 1/4 inch felts, and they are through a company called Hapad, Hapad, Hapad. I have YouTube videos on these. You can absolutely send these to your patients. I send them to my patients and I say, this is how you put the Met pad on your foot. This is how you put the Met pad into your insole, right? So I'm making sure that they're using it in the right place, because if it's too far forward, it's going to cause more pain. Or they're using foam, or they're using silicone. And just in my clinical experience, 1/4 inch felt is my go-to for these patients. Okay. Slight heel lift. So you may want to avoid being completely barefoot in these individuals, and that's fine, right? It's fine, right? Maybe you just have a slight heel lift. You could still go in minimal shoes. You could still go in a Vivo barefoot or a Zero shoe or a ballet flat, but just put a little heel lift in both of them, right? Small, just to take a little bit of tension off of the fact that they are in a plantar flex position. Okay, especially if your patient or individual is feeling symptoms, Achilles, plantar fascia, things like that. You want to do a slight heel lift. You can do what's called a valgus post. So right here, these are posts, and these are silicone based. They have an adhesive on the bottom. You would put them in your shoe. So let's say if I took out this post and this person was standing like this on the outside edge of their left foot. As soon as I put something on the inside edge, I'm going to tilt them in, drop them towards the inside of their heel, which means they end up neutral. Okay, that's essentially how posts work. And this is the theory behind the Naboso foot wedges. of how we want professionals or individuals to use the wedges to correct their foot posture to get better alignment from the feet all the way to the hips. So if you were training barefoot, you would essentially put the 10-degree heel wedge on the outside of the heel, just like this post, and they would do their squats or their exercises. Inside the shoe, you could put this so it's going to tip them into neutral and we find a more balanced position. Okay, that is posting. And then because a lot of people with higher arches over supination cavus feet have a lot of hypertonicity, so just tight muscles, right? Rigid foot, rigid hip, rigid muscles, hypertonicity. I like to use vibration-based platforms or vibration-based muscle relaxation to allow that muscle to relax and get an increased range of motion. This is very important for those that have a neurological cavus foot. Using vibration can create a relaxation, so then you could stretch the toes, maybe get a little stretch of the ankles, etc. Okay, so that's going to be general specific recommendations. Now, I often get asked, or I see patients who have high arches, and then they tell me that they're using orthotics. And in 12 years of practice, I've never prescribed orthotics for a cavus foot, for a rear foot issue. Now, if I did a orthotic for a cavus foot because they really want the metatarsal pad, or I have to do a first ray cutout, like a reverse Morton's extension, that is different. But I've never done an orthotic to a cavus foot to support their arch. I'm trying to think of where I would do it. I would never bring a rigid arch support to a rigid foot and put it in a rigid shoe. It just doesn't make sense to me unless you are doing a plastizote accommodative insole because someone has a neurological cavus foot. But to me, that's different than an orthotic. That's a different mechanism, right? So just so you know, if you've ever been curious about that, of giving arch supports to a high arch foot, I've never done it. It doesn't make sense. I would rather focus on unlocking the foot and bringing mobility. Okay. If I have to address the forefoot, different conversation, right? All right. So I want to share with you a case study about a cavus foot. This is a patient that when I was doing my mentorship, she presented with it. So she is a 44-year-old female. She's a teacher, so she has to stand on her feet. So right away, I need to be thinking a little bit different with this individual, right? So 44, teacher on her feet all day, pain in her midfoot with any type of walking, no issues exercising or anything like that. So pain in the midfoot. Feeling of crunchy sensations on the bottom of the foot, does not have a lot of toe extension. So if she's sitting here, she really can't bring those toes up. Too much pulling bottom of the foot. She was fitted for orthotics from a visit from a different podiatrist, and now she's here. She's just getting my opinion on this. How would you start to approach this with my midfoot pain, tightness in the bottom of the foot, trouble extending the digits, and crunchy feeling, all of that? Okay, so here is her foot. So she has a higher arched foot, right? More of this cavus foot type. And what I want you to appreciate, and I can explain this. So right here, you can see her plantar fascia. Do you see that band right there? So that plantar fascia. Okay. So now I want you to take your foot, and I'm going to show you my foot, and I'll do it with it, and then you can join me as well here. So I'm going to have you take your foot and just relax your foot. Okay. So I want you to feel the bottom of your foot where your plantar fascia sits with your foot relaxed. Do you feel any plantar fascia band? I don't feel any. I don't know if you guys do, right? Okay. Now I want you to put your foot in the middle of your arch, or your hand in the middle of your arch, and then take your toes and extend them back. As soon as you do that, I don't know if you can appreciate that now my plantar fascia is jumping out, right? Or if I put my hand under my foot, oh yeah, I can totally feel that plantar fascia tight, right? My plantar fascia is taut, okay? That is a normal presentation in a foot. This patient, when her foot is relaxed, she can still feel the tightness of her plantar fascia. And that is something that is actually very common in individuals with a cavus foot. Individuals that have a cavus foot have a plantar fascia that is at end stretch, is what it's called. So an end stretch to their plantar fascia. Just standing, her plantar fascia is like this. So as soon as she moves, there is no elasticity or no play within her plantar fascia for her to dynamically load and unload that tissue. Also, as she's standing here, what happens when you extend your toes up? We just did it here, right? When you pull your toes up, you tighten your plantar fascia. But if her fascia is tight with her toes relaxed, well, she has no play within the tissue to extend her digits, right? So this is very important to understand because this is characteristic of people with high arch cavus feet. Is their plantar fascia is at end stretch, just at baseline. So then they are at high risk of getting plantar fasciitis. They're at high risk of getting plantar fibromas. I actually just saw a patient this week who is a bilateral fibroma in her plantar fascia. And sure enough, she has a high arch cavus foot. She also has plantar fasciosis here because she's at constant end stretch. Okay. So something that is important to think about, right? And then, of course, compound her foot type with her job as a teacher, having to be on her feet all day. Well, no wonder she's going to start to get these symptoms, right? So these are some things that I just think about when I hear something like this is she's a teacher, she's on her feet long hours, she has pain on impact movements such as walking. So there's something about the stiffness of her foot. If you get pain when you strike the ground, there's something that your foot is locked. What is her daily foot release technique? Is she doing anything as far as releasing her feet? Maybe, maybe not. I don't know. We got to start it, right? Get some toe spacers going. What shoes does she wear at work? If she tells me that she's wearing a ballet flat, like a flat ballet flat at work, even though I absolutely love minimal shoes, let's say she's wearing like a minimal shoe company's ballet flat, absolutely not. Standing long hours on concrete, especially with a high arch, with a baseline taut plantar fascia, we cannot be in something that is totally barefoot. Just the foot is going to break down at some point. We are defying physiology here. So what I would say for her is that I would get her in something. I would actually want her with a little bit of a drop, maybe a little bit of an arch support, even though the arch support is not about supporting the arch. It's just about somehow redistributing pressure. Maybe she would want a metatarsal pad, right? Maybe, I mean, she might actually do really well in the Hoka, not to be like putting too far out there, but the fact that she is on her feet long hours with a rigid foot and a baseline tight plantar fascia, we need to think of that when we're approaching them. Okay, so that's how I start to think of these patients. Last thing that I want to focus on is about unlocking the midfoot. This photo here is of a blackboard. And if you haven't heard of Blackboard, definitely check out Blackboard-Training, German company. There's some places that you can get it here in the US. And then, of course, there's some Amazon versions as well that you can get. But it is a board that essentially disarticulates the rear foot with the midfoot. So it creates this ability to invert, evert the rear foot, and then your forefoot should be able to stay stable, and then your rear foot should stay stable, and we should have that same inversion, eversion of the forefoot. And it's trying to bring that unlocking mechanism to the midfoot. So I like this. I use this a lot with my cavus foot patients, especially those that are feeling some midfoot symptoms. So this is something that you can incorporate as well. Okay, what I want to do before I head into some questions here is that I want to just kind of recap here so that we can take this information. Again, there's a lot more underneath this, but high level of what we can start to associate with the high arch cavus foot. Higher arches, rigid foot, pressure to the ball of the foot, retrograde pressure from hammer toes, an extrinsic advantage, limited ankle mobility because of the plantar flexion, risk of Achilles tendonitis, Haglund's deformity, plantar fasciitis, obviously ankle sprains is another one. What does it do to the hips? It can cause a lot of hip tightness as well. So any of that mobilization to the foot, I'm also focusing on mobilization to the hip. You could even do something like hip cars if you would like. That's where you're just kind of bringing some range of motion into the hip. Go to YouTube and search hip cars if you would like more information on that. All right, I'm going to answer a few questions here now. So Mary says, what would be the cause of a high arch but high over-pronation? Meryl, if you are still on, I'm going to have you just type that a little bit more so I make sure that I understand the question. I think that I do, but I don't want to go down something way more complicated when that's not what you meant. Okay, Meryl? That would be amazing. Thank you. Rusa, can someone have a cavus foot like this, like these, and not have any pain? Absolutely. Absolutely. Just because you have a cavus foot does not mean that you have to have pain. Do you get hammer toes with a flat foot? Absolutely, 100%. You can get hammer toes with any foot type. They're just slightly different types of hammer toes. Oftentimes, a cavus foot will have an extensor dominance, where pes planus will have more of a flexor dominance. Okay? Similar but different. Heather says, are Haglund's deformities also common with tight cleat wearing athletes? It's not the cleat that is creating the Haglunds, but those that wear cleats, such as soccer cleats and football cleats, which are stiff and they have a stiff counter, will irritate a foot with a Haglunds at a higher rate than a foot without a Haglunds. But the cleat isn't making the Haglunds. I hope that makes sense. Okay, so yes. Meryl, so just to clarify, people with a cavus foot should avoid zero drop shoes. Yes and no. They would have to be respectful of the fact that prolonged standing may start to hurt their Achilles tendon or their plantar fascia, which means the body's just telling them because of their foot type, let's bring in a little bit of support, a little bit of drop. Doesn't mean I try to not make black and white or A and B statements that cavus feet should never wear zero drop shoes. That's not true. That's not what I'm saying. It's understanding why that type of shoe may cause increased foot stress. And if you start to feel that foot stress, you just take a little shoe holiday and go into something with a little drop, do some foot mobilization. Then you could tease back into the minimal shoe and kind of dance back and forth. Okay. Would you still avoid arch support if the cavus foot was over-pronating? So, Meryl, I want to make sure that this is correct. So you can have a high arch, but then the heel is everted, but the arch is still high. That's what I thought you meant. Now, what that is, without making this too complicated, is that that individual probably has a forefoot varus that when they bring their foot down, they are compensating by everting the rear foot. I hope that makes sense. Okay. So here's your forefoot, here's your rear foot, forefoot, rear foot. If this is the forefoot open chain, but that's not how you're going to stand when you're closed chain, and you bring your foot down, now your heel is everted. So that is a forefoot varus that compensated into a rear foot valgus. That is what you're describing, Meryl. If that made absolutely no sense, then message me offline and hopefully I can incorporate more on that. Rue says, my reference to this question was to the metaductus. Oh, yes. So absolutely. Can you have a metaductus foot and have no pain? Absolutely. Absolutely. So would you not recommend the form insoles for this foot? You could, if you like it. Technically, they're arch supports. So Denise is asking about the Naboso form, which has a built-in arch. If they like the sensation of touching every aspect of their foot with the stimulation, then they're not going to get hurt. I have a higher arch and I love the form, and I use them in my slippers every morning that I get ready because I love to have every aspect of the texture touching all of my skin, which doesn't happen when I'm in normal flat insoles because my high arch. So it's not wrong necessarily, Denise. Okay. I can't find the heel lifts on your website. Where do I find them? So Susie, the heel lifts are not on Naboso. The heel lift, you would have to go to sole insole. I am going to send this for everyone. It is sole, like your soul, insole.com. You can message them. They have a discount code linked to me. I just don't know what it is. Sole insole, and they're called a post. It's a Velgus post. Really nice woman who owns the company. Okay, sole insole. The metatarsal pads, we don't sell those also on Naboso. That is HAPAD, HAPAD. Okay. When you have high arches, but your foot is pronating inward, what would cause this? I think that I've answered that, Meryl. For high arch people who want to do distance hiking, what are the best ways to support the foot to be able to handle this? Release the feet, use met pads, make sure you have increased foot strength, make sure your hips are mobile and strong. I try to bring as much as I can of the function into the foot versus overriding it with footwear. Just a couple more questions. Thank you guys so much. Ooh, we got some good questions. Okay. Are you recommending wearing the metatarsal pad all day? Yes, absolutely, if you need it. Cavus foot with heel dip, post-tip tendonitis. What is the best treatment? Hold on one second. I have long been taught that wearing flip-flops is the hardest thing that affects the knees and also what it does to the toes as they curl when they catch the strap. Yes. But it also affects the gait. What are your thoughts on this? Yeah. I mean, mechanically and functionally, using flip-flops or even slides that are not attached to your foot, any shoe that's not attached to your foot, you are changing the way that you walk because it's not attached. So as you pick up your foot and you swing through swing phase, you have to do something. Oftentimes people will grab the shoe with their toes and pick it up, or they'll circumduct and swing their leg through. So the ideal shoe is that you want it to be attached to you. Okay. Jonathan says that he bought the form for his high arches. Are you saying that I shouldn't be using them? Absolutely not. What I would say, Jonathan, is I would actually try them. Because what you might find is that using the form with the texture causes your plantar fascia and all that connective tissue to actually release a little bit, and that you get some relaxation of your calf muscles. So I would definitely try them. We have a very lenient return policy. So please even message them and say, Dr. Emily said I could return them even if you're past the window. I would rather you try them and see if they help you. I absolutely love the form. I think that most people have to give them a go. They just see the arch support and they just think, no. Sherry says, I have a cavus foot. My feet are different. Right foot has plantar fascia issues and metatarsal issues, but the left seems hyperpronate without those two issues. I also have fat pad loss. What can I do? Had surgeries years ago for hyperpronation, reverse pelvic. Ooh, Sherry. I feel like we're gonna have to take that one offline. I'm gonna give you my practice. Functionalfootdoc.com, thefunctionalfootdoc.com. That it's just a little bit easier for the sake of this to shift that offline. Okay, I am going to do two more questions. Is there a workaround for someone who has a cavus foot that affects them from bending their rear knee in a forward lunge since it's structural? Is there a workaround for someone who has a cavus foot that affects them from bending their knee in a forward lunge since it is structural? Well, then that's making it sound like they don't have ankle plantar flexion, not dorsiflexion. I want to make sure from this question that if someone is having pain when they lunge in the back foot that's in a plantar flex position, that are we actually just talking about like an ankle arthritis? And that's more of the question. And the foot type is part of the story, but it's really not the cause of the pain. So I don't want to try to put something in there that's not. So some of the questions, and this is why I absolutely love it, answering this question. So thank you so much for asking these, everyone. But sometimes what is hard is that I have a sentence, right? And I would love to have more information as far as for how long, what's this foot type, when do you feel the symptoms? So there's a lot of questions that I need to ask around it versus just saying, oh, you have heel pain, therefore you have this and do this. I try really, really hard not to do that so that I get the full picture and that the patients or the individuals actually get an accurate treatment plan based off of the uniqueness of how they're presenting. Let's just say that. Okay. So if I happen to ever not answer something just from a question such as this, please do not take it personally. It's just that I have a lot of questions that I need to ask you to better understand it. This is why I spend an hour with a patient so I can go back and forth and really, really just listen to what you're explaining. So I do apologize for that. What we're going to do is we're going to wrap up, but if you are listening to this live, or you're listening to the recording before Monday the 11th, then guess what? Tomorrow, our site goes on sale. We are kicking off the holiday shopping tomorrow, which is November 8th. November 8th through the 11th, we're kicking off our holiday shopping. It is up to 40% off in the US, Canada, and Australia. It is up to 25% off in Europe and the UK. So depending where you are in the world, please take advantage of this chance. And then we have a new product launching November 18th that will be launching, and it's for your hand. So get ready. No codes needed. Head to naboso.com and then stay tuned. We are going to have one more webinar in 2024. So you got one more chance to learn, and then we will resume right back at it in 2025 with our webinar series. If you have any topics that you guys would like, please message me on Instagram, The Functional Foot Doc. Send an email to orders@Naboso. Message Sasha, who's Sasha at Naboso or Sasha at EBFA Global, so that we can get your ideas of topics that you would like. Thank you guys so much. If I did not get to your questions, please inbox me and I will do my best to help you. Thank you all so much. Take care.